Good morning, everyone. I'm really excited to introduce Dr. Katie Gillis. Dr. Gillis is a professor at the University of Aberdeen, and Dr. Gillis's research interests really focus on the design and delivery of participant-centered trials from point of initial contact through communicating results to participants. Dr. Gillis leads research in the application of behavioral science to trial methodology, including framing problems of recruitment and retention as behaviors and exploring the opportunities to improve these through the design of participant-centered, theoretically informed interventions. We're going to hear a lot more about trial recruitment and retention in today's seminar. And please feel free to include any of the comments in the chat. And I think we're going to have some time for questions at the end of the session today. So welcome, Dr. Gillis, and feel free. Thank you.
Thanks, Anne, and thank you to Ian for inviting me to give this seminar to you guys today. I'm just going to share my screen and pop you into full slide view. So hopefully now you can see my screen. Perfect, I can see some nods. So as Anne said, I'm going to talk to you today about some thoughts on recruitment and retention in trials. What do we know and where are we going? But first of all, I'm going to set some expectations, okay? And this is an important message as well for setting trial participants' expectations about recruitment and retention. So I am not going to give you the panacea of how to solve all your recruitment and retention problems. If you were here for that, then I'm sorry, that's not going to happen. What I am going to do is I'm going to highlight why recruitment and retention are problems. We're going to consider what makes them difficult. And we're going to look at reasons that trial participants and staff involved in trials say they're difficult. We're going to look at the evidence as well in terms of what it tells us, in terms of solutions. And then I'm going to share with you some of the things we're doing in my team in Aberdeen to tackle this problem in a slightly different way. I'm just going to move you back over here. Okay. So I probably don't have to tell this audience what the problems are about poor trial recruitment and retention, but so that we're all on the same page, let's go through this a bit. So poor trial recruitment and retention have implications for both the internal and external validity of our trials. So at best, poor recruitment and retention can make our results unreliable, and at worst, they can make them completely unusable if both are completely fatal. The impacts in terms of poor recruitment and retention, one is a complete no-brainer, right? So trials that take longer to recruit and retain cost more money. But if we think about this and expand that concept for a minute with an example. So in the UK, on average, a trial participant costs about £8,500. That's the all-on cost. If we have a trial of a sample size of around 250 people, and we inflate that sample size by 10% to account for missingness, those additional 25 people are going to cost more than £250,000, which could be another feasibility study. So there are significant costs that can be sunk with poor recruitment and retention. One of the other aspects is from an ethical perspective, right? So trials that take longer to recruit and retain, it means that it's going to take longer to identify whether potential treatment has benefit or worse, it has harm. And so you're indirectly exposing people to unnecessary harm, but also foregoing effective treatments being rolled out into the healthcare system. The other area, which there's now a lot of conversation about in the UK, and I'd be really interested to hear about what the situation is like in the States, is considerations about recruitment and retention in terms of carbon. So trials that have to recruit and retain more people are going to use more carbon and will have impacts on environmental sustainability. But it's not just me who thinks that recruitment and retention should be a research priority. So this piece of work done by Catherine Tudor-Smith in Liverpool and colleagues, which was done more than 10 years ago now, and is being updated. In this prioritization exercise, looking at what are the priorities for trials methods research, recruitment came out as joint first, and retention came out second with choosing appropriate outcomes. And I believe you had a seminar from Professor Paula Williamson at the end of last year on the reasons why we need to choose appropriate outcomes and core outcome sets. Okay, so let's take this example just a little bit further to think about why it matters. So I was looking when preparing this talk at clinicaltrials.gov. So by the end of 2024, there were more than 43,000 trials registered just in 2024, just for that 1 year. The number of trials being registered annually is going up year on year. Let's think about those 43,000 trials. Assume they have a modest sample size of 150 participants. That's more than 6.5 million participants required to be recruited and retained in trials just registered last year. If we look at the whole of clinicaltrials.gov from inception, which albeit is 24 years, there's more than 500,000 trials, and those trials, again, on a modest sample size of 150, need more than 78 million participants to take part and stay in those trials until the end. So it's a significant problem if we don't know how to do this well. Okay, so now we're going to look at what the literature tells us, so what we do know. So what's the scale of the problem? So this piece of work was conducted by Richard Jack and colleagues in Sheffield, and they looked at a cohort of NIHR, so the National Institute for Health Research, which in the UK is pretty much an equivalent of NIH. NIHR is Europe's biggest funder of publicly funded trials. And this team took a cohort of nearly 400 trials, and this work has been done previously, and this was an update to look at what proportion of those trials had problems with recruitment. So they were able to demonstrate, and this picture looked a bit better than it had previously, that 63% of those 388 trials did recruit to target. 30% of them had to revise the sample size, usually downwards, and also a proportion of them needed to extend recruitment. So it is still a problem. So why, I mean, again, I probably don't need to tell this audience this information, but why is recruitment challenging? What makes it difficult? To me, it's because we have individuals, so people who exist in complex systems, right? And you have a trial participant who interacts with trial staff, that might be a clinician, who are situated within a local organization, who are situated within a national organization, a healthcare system often. And then around that, you have this wrapper of regulatory frameworks. But I think that this kind of onion diagram makes it look nice and simple, right? It doesn't, it looks like this. So this isn't about trial recruitment, but this is to kind of use the image to help you think about that, you know, this might be the participant and they exist in their own complex system. And then you have the healthcare professional who exists in their own complex system. And it's the interaction across all of these pieces. And I'm going to pick up on this again later when I show you some of the evidence. So trials involve people, right? And what does the evidence tell us about what potential participants and healthcare professionals say about what makes it difficult? So there's this really nice piece of work led by Catherine Houghton and colleagues. It is in the Cochrane Library. It's a qualitative evidence synthesis. So it has taken primary qualitative studies that have explored the reasons why patients do or don't take part and combined that together in a synthesis so that you're not just looking at an individual study, you get a view across a number of different trials and different contexts to come up with kind of big ticket items on what drives the decision about whether or not to take part. So they came up with this infographic to summarize their findings, which essentially in a nutshell talked about three main areas. This included how trial information was communicated and which elements of the trial were considered burdensome and required a big commitment from participants, and that influenced their decision. There was also this theme, there was also a theme related to personal factors, such as how other people, and that might have been the person they were having the conversation with about taking part in the trial, it might be family and friends, but about how that influences their decision, how personal understandings of benefits and harms could impact as well. The last area that they focused on, and again, I don't think this is necessarily new, but it's good to have it evidenced, is this concept of what's been termed conditional altruism. So the idea of taking part in the trial to contribute to the greater good, but with the condition that you get something back for yourself, which might be access to treatment, it might be additional visits with your healthcare practitioner. So they came up with this, but again, as I said, it's not something that we didn't know, but now we have the evidence, and this is going to be important for something that I'm going to say in a few slides' time. So that's the potential participants. What about trial teams? So what do they say that influences recruitment? And again, this is a qualitative evidence synthesis. This was led by Nicola Farrar in Bristol. So they looked at individual studies where recruiters had talked about their experiences of trying to engage people in trials, and they brought that together to look at what the big ticket items were. So there are 5 core areas where they talked about recruiting to RCTs in a clinical environment can make it challenging to identify patients. It might be difficult for patients to attend hospital for these treatments or appointments. There might not be any physical space or actually time to accommodate the discussion that's required for a trial, and there may be competing priorities for research. Another one was around enthusiasm for the RCT. So lots of positive enthusiasm from the initial trial team and to contribute to the evidence base, but people who are involved more peripherally may not have that enthusiasm and may create barriers to enable the trial to run. Number 3 is really around gatekeeping, right? So, and this comes up a lot in the literature around people making judgments about whether to approach the patient that aren't based on the eligibility criteria. So there was a paper published in the early 80s that's, I love the title of, they call it The Good Study Patient. And it's this concept of people making judgments based on whether the person will consent, whether they'll take the intervention as described, and whether they'll complete outcome assessments, not whether they just meet the eligibility criteria. There were issues around communication challenges, and this really links to recruiters making their preferences explicit, and then that influencing the patient's decision making. And then there is this interplay that exists between recruiter and professional roles. So the idea that first and foremost, someone in a clinical role has a caregiver and advocacy role for that participant, and the trial comes second. And again, beliefs about equipoise and preferences can have interplay there as well. So that's kind of what we know, what the literature tells us of the reasons why patients and healthcare professionals find recruitment difficult. And like I said, this is probably things that you already know, that you've experienced in your own practice of running trials. So then we want to kind of ask the question, okay, so what are people doing at the moment? What do they do to try and improve recruitment? And again, at the end, I'd love to hear whether what I'm going to say on the next slide resonates with you or if you use different things. So this list, I have to acknowledge Adwa Parker for this list. She pulled this list from, again, NIHR funded trials and the types of things that trial teams are saying that they use routinely to try and improve recruitment. So there are 2 ways this can be applied, one at the design stage and one during conduct. I should also say the caveat is that I'm not saying that you should do these things to improve recruitment. So I'm not advocating for cluster designs just to improve recruitment. That is not necessarily the reason you should apply that rationale, but these are some of the things that people talked about. So an open versus a blinded design, patient preference, cluster designs, and having patients and public as partners in the research process and getting their input into the recruitment process. Then in terms of conduct, lots of things that focus on the participant information leaflet. So people are optimizing by length and language, thinking about different modes of delivery. So using infographics or video or social media, and then some aspects focusing on the recruiters themselves. So training and feedback. So these are things that are used routinely. What does the evidence tell us about the effectiveness of these types of approaches? So some of you may be aware there is a Cochrane review led by a colleague of mine, Sean Treweek in Aberdeen, which has looked at the effectiveness of recruitment interventions. So this is where you have a trial evaluating, say, a patient information leaflet on paper versus a video-based information leaflet. And that comparison is embedded within a host clinical trial. So you're testing which way is most effective to improve recruitment. This review includes 68 studies. It has 72 comparisons. So there are 72 different interventions. And some of them are the things I mentioned on the previous slide. So this patient information leaflets, different modes of delivery, some targeting recruiters, but they tend to target participants. When applying grade to the evidence, there are only 3 things that we can say of those 72 comparisons with high certainty evidence that they can improve recruitment. So these are specified here. So the first is having an open rather than a blinded trial. But clearly that can't happen in every trial design. It can have impacts on the rigor of your trial. The other is telephone reminders to non-responders. So this might be where you've invited people to take part in a trial, you haven't heard back, you phone them to remind them that they have this invitation. Again, not applicable to all trials, I know in the UK that some of our ethics committees have issue with this because if a participant hasn't consented, we can't hold some of their data, so that would become impossible to call them. And then there's this patient information leaflet development process using what's called a user-centered design. These 3 studies are in the Cochrane Review, so if you want to learn more about them in detail, then you can head over to there. So these are the interventions that we think work, and we have high certainty evidence that that would be the case. Let's think back for a second to what I told you about what influences a participant's decision to take part. Some of it was about the information being shared, but there's certainly this aspect of, say, conditional altruism. So, what's in it for me and wanting to give back. None of the interventions in this review focus on that aspect, or indeed many of the other aspects that participants cite as being challenging for their decision. So to me, there's a bit of a mismatch, right, between what people tell us, and that includes recruiters, what people tell us makes it difficult, and the solutions that we're developing. And I think some of the reason for that, and sorry, this image is a little bit grainy, but it's based on the Islagiat principle. So if I was in the room with you now, I'd say, okay, can you put up your hand if you've heard of the Islagiat principle? It stands for, it seemed like a good idea at the time. So we do this when we run trials because we don't have tons of evidence on which to base our decisions. So we do what we did last time, or we do what we did in the trial in the same context. But maybe we need to start thinking a bit differently when we're trying to develop solutions to target some of these challenges. So this is then where I'm going to tell you a little bit about what we've been doing in our group. And this is where we think about the problems of recruitment and retention as behaviors. Okay, so I'm not a behavioral scientist. I am a trials methodologist, but have worked and do work very closely with behavioral scientists. So the idea here is that trials depend on behaviors. Okay, so they rely on people, and that might be patients, healthcare professionals, trial staff, performing actions or behaviors, and that might be approaching a patient, it might be receiving or delivering an intervention, it might be attending a clinic, returning a questionnaire, collecting data. Trials to me are just made up of lots of different behaviors. That kind of spaghetti picture that I showed you earlier, lots of those things are behaviors. And there are many influences on these behaviors, and the behaviors are pervasive, they're contextually determined, but really importantly, they are amenable to change. And behavioral science has demonstrated that it can support behavior change of patients and healthcare professionals to improve both short and long-term outcomes. So by that, I mean, you're probably very familiar. Some of you may even run trials of behavior change interventions. Often this has been used in lifestyle, so weight management, smoking cessation, targeting patients. There's also a lot of work that's been done with healthcare professionals, getting them to adhere to guideline recommendations. So there is a ton of evidence about how behavior change science can be applied in positive ways to change people's behaviors. And applying it in trials isn't necessarily new. We've done some systematic reviews where we've looked back, and this has been going on for quite some time, but there's not been a lot of traction and energy behind it. And so that's what we're trying to do now, and to develop tools that other teams can use in order to use this approach. So let's talk about how we do this approach for a bit, and I'll give you an example from a trial that we did this in. So we kind of have this 3-step process that starts with behavioral specification. So this is defining the problem, okay? And this is essentially asking the question of who needs to do what differently, when and where to whom. And I'm not claiming that we are coming up with all of the tools to do this. There are loads of existing tools that we're leveraging from behavior change science already. So there are some existing frameworks that you can use to specify the behaviors, and I'm going to show you how we've applied them. The next step, once you know what it is you're trying to change, is to understand the problem better. So a behavioral investigation. And this might be through an analysis of existing data, or it might be through collecting new empirical data, so through surveys or interviews to understand the problem in more detail. This phase is essentially about identifying the determinants of the behavior. What do you need to do more of, and what do you need to kind of dampen down? And through this stage, once you have that information, you can develop solutions, again, using existing theories, models, and frameworks and tools within the behavior change science literature. And the things I am going to talk about today, and I'm happy to answer questions on them at the end and the reasons why we've applied these, is something called the behavior change wheel, developed by Susan Mickey at UCL and colleagues, and specifically a framework called the theoretical domains framework. So if I say TDF, that's what I mean. It's an amalgamation of a number of different theories. I'm sorry, those pop-ups keep happening on my screen. And then the other thing, just to mention, because I may slip into saying it, is there's this taxonomy called the BCT taxonomy. BCT stands for Behavior Change Techniques. BCTs are essentially the minimum active ingredient in a behavior change intervention. So if you think about the intervention as a cake, the BCTs are like the egg, the flour, the sugar. Okay, so they're these individual components and you can dose them up and down, you can deliver them in different ways. What's key about these BCTs is you can map them through different mechanisms of action so when you're evaluating them, if they're not having an impact on the behavior of interest, you know, okay, well, we need to change it up. It's not just saying we need to address the patient information leaflet to improve recruitment, for example. Okay, so let's look at an example. The first thing to say, and if you take one thing away from my talk today, this would be the thing I'd really encourage you to take away. So recruitment is not one thing. So recruitment isn't a behavior. Recruitment is a concept that's made up of lots of individual behaviors. And, you know, so saying to our centres, we need you to improve the recruitment of participants. Personally, I don't think that's massively helpful. It might be that what you need to say to them is, okay, in your centre, you need to be screening more patients because we can see that that's where the problem sits. For other centres, it might be, okay, you need to approach more patients because we can see they're being screened in, but they're not being approached. So understanding that behavioural specification is really important. So here's how we applied it to a trauma trial. So this was a trial that we ran in our unit a couple of years ago. It was published, I think, last year before in JAMA, if you want to read more about it. It's called the UK Reboa trial. So patients present in the ED with exsanguinating hemorrhage, so bleeding to death, and they are randomized to either standard major trauma center care or standard care plus this Reboa catheter. So the Reboa catheter is inserted through the femoral artery. The balloon inflates to keep the blood in the upper half of the body so that you could administer some emergency treatment before removing the catheter and stabilizing the patient, etc. So we believed that this trial was going to have some interesting challenges. I should say as well, this work that we did with the behavioral optimization has all been published. So if you want to find out about it in detail, you can head over to trials. So the first thing we did was this specification, right? So who needs to do what differently? What are we interested in? So we use ACT, which stands for action, actor, context, target, time. So we look at the action, that's the behavior. And here there were 3 different behaviors around assessing eligibility, randomizing patients, and delivering the intervention. The actor, so the person performing the behavior, here was clinical staff. The context, as I said, was in the ED for code red patients. The target was patients with exsanguinating hemorrhage, and the time was throughout the recruitment period. So that's the specification. Then what did we do? This diagnosis phase. So we conducted interviews, and these were informed by this framework I mentioned, so the TDF. We conducted interviews at two time points. First of all, with sites who were kind of the early adopters of the trial, so those who got going fairly quickly. And then we conducted interviews at a later time point, again with some of those same sites, so once they'd had time to kind of bed in more, but also with sites who may have had a near miss with a patient, so they hadn't been able to randomize or they hadn't randomized any. We took a selection of sites. The other thing we did was that we observed the training for these centres. So this trial, for many of the centres, they wouldn't have delivered this intervention before. So there was a lot of clinical simulation involved in the training. And also there were educational sessions where the trial manager presented and talked through. So we observed them to look at how the trial was being discussed. And we wanted to think about how we could add some behavioural analysis and techniques into the update. So what did we find? Okay, so I'm just going to give you the high level stuff. As I said, it's been published if you are interested in learning more. So there were these 4 core domains that came up as being important from the TDF. So TDF has 14 domains, and then through the analysis, you can identify the core ones that are important, and then you develop the solutions based on those core activities. So here people talked about aspects of skills, so being able to recognize eligible patients. So I mentioned that the patients had to be bleeding to death, so have a definition of the definition of exsanguinating hemorrhage isn't clearly defined, and so this made eligibility assessment tricky. There was this tension between the scarcity of cases, so we didn't have a high throughput of patients. We didn't expect to see many patients who would be eligible. But this is set up against the fact that it's a skill-based intervention where some of the sites haven't delivered this. And so there's a tension between the two of those things. There was a piece on waiting to see if patients needed Reboa. So I learned so much doing this trial. I hadn't worked in trials in the emergency department before. I've predominantly worked on elective surgical trials where you assess a patient, they don't tend to change. The clinician's equipoise doesn't tend to change. In Reboa, the eligibility assessments and decisions about whether or not to recruit could change literally within seconds because something would happen with that patient. Environment, context, and resources. So this is really the context where, again, it's linked to this scarcity of cases. And then one of the big ticket items, which is true for many trials, was around social influence. So this perception of an individual and colleagues' equipoise was really important. So some centres were very pro-Reboa and some centres less so. And you could see that being played out on decisions about randomisation. And that's linked also here to enthusiasm for the intervention as well. So some centres were already using it, so really had a belief in its continued use. Okay, so then how did we develop this into solutions? So you don't need to be able to read what's on this slide. Again, this is kind of talking you through the process of what we did rather than the detail. So we take the findings from the interviews. Okay, so this is the evidence from the people involved in running the trial day to day. And we link those relevant domains to the relevant BCTs. And again, this is all evidence-based. There are tools, publicly available tools that you can use to map these through, and it tells you whether there should be a link and how much evidence there is to support that link. You then can develop it into what the proposed solution will be. And this is at just what we call an intervention function level. And I'll give you some examples on the next slide. We then proposed content. And then, some of the things we were proposing were possibly unfeasible, but at this stage we propose everything, and then we go to the trial team and we work through a process using this criteria called APPEASE, which I'm not going to remember the full acronym for, but it's about affordability, practicability, effectiveness, I can't remember what the second A is, safety, and ethicality. And you have a discussion with the trial team about, okay, do we think this has the potential to work? So you can see we had a long list of things. So what did we take forward? So the things that we were able to implement and took forward was, first of all, an infographic using, so the intervention function here is persuasion, which is about using communication to induce positive or negative feelings so that you simulate action. And this has behavior change techniques embedded within it, that are linked directly back to our interview findings. So talking about, for example, here, telling people that they're adding to the evidence base for methods of management. This was one of the things that came out in the interviews were people saying, it's really important for us to be involved in the first clinical trial, randomized clinical trial in this area. Having the clinical CI and the clinical training lead, this is what's called credible source. So various things embedded within that. And another aspect was the training. So I mentioned we observed the training and then we went back and updated it and fed in some of these behavior change techniques on key points, such as, issues around equipoise, really trying to push people to consider what made it easy or difficult to randomize patients. There were 2 other solutions we came up with. Unfortunately, we didn't have time to implement because the trial was actually stopped early for harm. The trial is published, so if you want to read more about whether or not using this Reboa catheter is a good idea, you can check it out in JAMA. Okay, So that's an example from recruitment about how we use this approach. We're going to switch tack now and talk about retention. You might be wondering why Cinderella is here. So me and a colleague sometimes joke about that retention is the trial conduct Cinderella, okay? And the reason we say this is that if you don't pay attention to it at the beginning, it has the potential to come along and steal the show. So it's worth not forgetting that retention is important as well. And to me, very connected to recruitment. There is evidence in the literature that things that happen at recruitment, and I'm going to tell you a bit more about this, can impact whether or not a participant stays in the trial till the end. You could argue as well an experience during the trial can impact on whether they may participate in a future trial. So what's the scale of the problem? So for retention, some researchers have suggested this simple 5 and 20% rule of thumb. So less than 5% of missingness probably leads to little bias. Greater than 20% potentially has serious threats to validity, and anything in between has intermediate levels of problems. From that work I showed you earlier on about the assessment of the recruitment problem in NIHR-funded trials, they also looked at retention, and they showed that 50% of trials have lost to follow-up of over 11%. And you may think, well, it doesn't sound like retention's too much of a problem. So I think this work, and the last bullet point from Michael Walsh and colleagues, is even more important. So they found that around half of all clinical trials could have been that they looked at could have been overturned if the outcomes from the non-retainers were known. And they termed this the fragility index. And I really like that idea that thinking about poor retention can make your trial really fragile. Okay, so now I'm going to take you through what we did for recruitment. So we're going to look at what does the evidence tell us about the reasons why participants don't stay in a trial until the end. So this was work that our group in Aberdeen led a couple of years ago. We're currently updating this qualitative evidence synthesis. So we looked for studies that reported the reasons why patients had said they couldn't stay in a trial till the end. And as a slight side, we identified 11 studies looking at this problem. There are about 500 that have looked at the reasons why people do or don't take part in the beginning. And I can happy to talk about later on about why there is such a discrepancy. So essentially what we found, and it kind of comes back to that spaghetti diagram again. So there is a complex interrelationship between an individual and the trial processes and procedures. So the trial is not the participant's priority. It's our priority as the team who want to successfully deliver that trial. But people have loads of other things going on in their life, and various other influences came in to this complex interplay. I suppose, some of the things we were expecting to find did come up. What we didn't consider was that overall, some of these findings suggested that the informed consent process had actually been suboptimal, because some of the things that people talked about could have been dealt with if at consent they had had their expectations set about what they could expect of the trial and what the trial could expect of them. Again, this interconnection between those two processes. So this is about what participants think. This is what the evidence tells us. What about what trial teams think about retention? So unfortunately, there isn't a qualitative evidence synthesis, but there is this nice study from Anne Dakin and colleagues from Bristol. And actually, I could even just not tell you what they found. I think the title kind of says it all: recruitment, 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 the need to focus more on retention. But some of the highlights of the things that they identified were that there are recognized factors that influence retention. So they talked about, the planning of when we design our protocol, that trial teams do include thinking about newsletters and reminders, possibly incentives to try and incorporate and enhance retention. Also things such as the choice of outcome, trying to use registry-enabled trials and use routine data. There is this relationship that exists between a trial participant and the team members involved in trying to improve retention. And building that relationship was important to trial team members to try and enhance the retention. In the UK, and again, I'd be really interested to hear about if this is the same in the States. In the UK, there is a national focus on recruitment, pushed by our funders and by some of the ways in which NHS centres are remunerated for their trial activity, where it's all based on recruitment figures and not necessarily on retention. And they also talked about largely monetary incentives targeting participants, which they felt were okay, but sometimes could have undue coercion. And then the unrecognized influences talked more about the moral compass of individuals. So people saying, thinking about, well, if that was my mum who was in that trial and I've already contacted them to remind them to complete the questionnaire, I don't want to have to do it again. The experience of trial team members, so more experienced members were happier to, I don't want to say challenge, but if a participant calls to withdraw from the trial, they felt more able to have a conversation around why they felt the need to withdraw, what is it they wanted to withdraw from, those kind of conversations. And then again, this issue about the unconscious influence of incentives, both on participants and staff. So I think we recognise that retention is challenging from both a participant and a trial staff perspective. So again, what happens currently? So Anna Kearney in Liverpool did this piece of work where she surveyed the CTU, so the clinical trials units in the UK, and asked them, what are the strategies that you use routinely to enhance retention in your trials? So again, thinking about different phases. So at the design phase, people talked about aligning their data collection with routine care, or using health systems data to think about outcome collection. In conduct, the most widely used strategy across all CTUs in the UK is to send newsletters to improve retention. There were other strategies such as prepaid envelopes if it's a postal questionnaire, telephone reminders, investigator meetings, flexibility in appointment times. But the difference here is that there are methods that you can use during analysis to think about how you can make up for that missingness. Clearly, you can't do this at recruitment to make up participants, but you can use methods such as imputation during the analysis stages. So they also talked about that as a strategy. So what does the evidence tell us about the effectiveness of some of these strategies that people are using? So our team led the update of the Cochrane review. So this is the sister review to the one I mentioned before on recruitment. So again, this is where studies randomize participants to say a newsletter or no newsletter within a host clinical trial, and then look at whether that improves retention rates. So again, there were over I think there's 69 studies in this review with around 60 or so different comparisons, so different interventions. And for retention, the picture is worse. So there's no high certainty evidence for any of the comparisons. There was moderate certainty evidence for a couple of things. So a pen at recruitment. I'm always baffled by this, right? So giving somebody a pen at the recruitment consent phase seems to help improve retention. Go figure. Then there's self-sampling kits. This is only relevant for, this was a study that was looking at sexually transmitted infections, and so needed biospecimens. So again, not relevant for all studies. And then financial incentives with a prompt or a reminder also seemed to improve. What seemed to have a negative effect was addition of a diary. So asking people to complete a diary in addition to usual follow-up should probably not be used. So let's move to this behavioural approach that I mentioned, and let's think about retention. And again, retention isn't one thing, it's a concept that has many different behaviours that are specified within it. So we, excuse me, we conducted this piece of work in a trial called Seagal. So this is a surgical trial comparing surgery to no surgery for uncomplicated symptomatic gallstone disease. And participants were being followed up by postal questionnaire at various time points from, I'm not going to be able to, it's 6 or 9 months up to 24 months. Some of whom will have had surgery, some won't. And the primary outcome was all about pain. So getting them to self-report their pain. So here we were interested in two behaviours and how they impacted on retention. One was that of the participant thinking about return of the questionnaire, excuse me. And the other was about how clinicians were discussing the trial with participants at the point of consent. And we chose this based on the qualitative evidence I'd shown you that had suggested that sometimes a suboptimal informed consent process may have impacts on retention. So we worked through the behavioural specification of ACT for each of these. And then what did we do in terms of the diagnosis? So we took two different data types. So we conducted, again, these theory-informed interviews with participants who hadn't completed one of the follow-up time points, so had not been able to return a questionnaire. And we also had been audio recording the consultations that happened within the trial at the point of consent, and we analysed those to think about this time how retention was discussed. So what did we find? So this might be quite small, but don't worry, I'm going to talk you through the bits that are of importance. So in the interviews, these are the interviews with trial participants. The bottom thread here is the relevant theoretical domains that we're lighting up, and the top part is the exploratory themes. So kind of what you'd see in a more traditional qualitative analysis. And so some of the things people were talking about was, so let's think about the significance of questionnaire non-completion. So this might be people not realizing, they'd say, well, I didn't complete the questionnaire because it asked if I'd had pain in the last 3 months, and I haven't had pain in the last 3 months, so I didn't complete it. We hadn't made it clear that we want to know if you've not had pain because that's important as well. One of the other issues was because there were multiple time points and the same measure was being sent across these time points, a lot of people felt like, oh, I completed this last time, and not realizing why they had to complete it again. This area of unclear expectations of trial participation. So again, that comes back to what was being shared at the point of consent, and clearly that hadn't been made clear. So there were other areas as well. Again, this work is also published if you'd like to read about it in more detail. But we mapped these important themes and the data from the interviews to the TDF so that we could then develop that into solutions. So the other thing we did was we listened to the consultations and were able to say, okay, well, actually in 79% of these consultations, there is no discussion of retention. It doesn't come up at all. And if it is discussed, it's discussed for a really small proportion of the time. And sometimes that information was actually was incorrect in terms of the timing of the questionnaires or who needed to complete them. So using that data, we developed three kind of treatments or interventions. So one was around training. So this was going to our sites and doing a training event where we shared the findings. And what was really interesting here was the site said to us, well, retention isn't our problem. And I found that fascinating because I was thinking, well, surely anybody who's in the business of recruiting patients should care about retention. But the way that they viewed it was, the sites were doing all of the work to get the patients in, and then the patient was discharged, either after they'd had their surgery, or if they weren't having the intervention, they go home after the consultation with the surgeon. Our site office did all of the follow-up. So there was this disconnect between people seeing it was part of the expectation on them as the trial team. So we did some training around that. There's also then a piece on education where we adapted our patient information leaflets so that the expectations of the trial were clearer. And there was another piece on education where we developed newsletters that had these BCTs again embedded within them that were targeting these key domains of relevance. And we did these for both staff and for participants. Okay, so I'm conscious of time. In the last couple of slides, I just want to also show you how this approach, I've shown you how it can be used prospectively to try and identify problems. We can also use it retrospectively, and we've been doing that in two main ways. So one of them is where you can use a behavioral approach, and specifically this BCT taxonomy, so these behavior change techniques, to deconstruct interventions. So we've been looking back at the retention interventions, and we're working with a group in Ottawa who've been doing this for recruitment to try and understand of the interventions that seem to have a signal of effectiveness. Are there key components within them that we can start to build on to develop more effective interventions? So that's work that's ongoing. And then the other piece that we're doing is these qualitative evidence syntheses, which I've shown you at earlier points in the presentation. So understanding clinician, healthcare professionals and recruiters' perspectives, and understanding patients' perspectives about recruitment and retention, and then mapping these to these theoretical frameworks, again, to identify what the kind of almost low-hanging fruit, right? So where should we focus our efforts on interventions that could be applicable, behavior change interventions that could be applicable across studies? And I'm going to skip this slide, but just in the interest of time. So what can you do now based on what I've told you? So I said, currently the way the evidence is, there is no silver bullet to say this is the thing you should do. There's lots of suggestions for good practice. So we need to be developing solutions and evaluating them to add to that evidence base for sure. But I would encourage you to, when you're thinking about recruitment and retention in your trials, to specify the behavior. So don't just think about it as recruitment. Think about this idea of who needs to do what differently, when and where to whom. Can you use existing data? I haven't shown you today, but we do a lot with patient flow data for recruitment. So looking at screened, eligible, approached, and randomized. And we can use that to identify key behavioral targets of where we want to intervene. If you can't conduct in-depth qualitative studies, which I realize there are resource and time implications for, then even talking to patients and staff about what they see as the core challenges, and then trying to map that back on. And what I haven't talked about at all today are also considering inclusive and greener approaches to your recruitment and retention. Big push in the UK at the moment on these areas. So to summarize, recruitment and retention remain to be significant challenges for clinical trials. I would argue there's still a disconnect between what patients and trial staff highlight as the problems versus the interventions to improve them. And I would argue that behavioural approaches do offer potential for solutions. And if you've enjoyed hearing about some of this methods research, I would encourage you to join the TMRP. You can scan this QR code. I can send a link afterwards. It's it's an international initiative led from the UK, where we bring together people who are interested in trials methods research and sometimes shoot the breeze, sometimes put in funding applications, but it'd be great to see some of you there as well. And thank you.
Excellent. Thank you so much, Dr. Gillis. I think we do have some questions that will come in the chat. Feel free to post your questions, or you can unmute yourself if you have a specific question you'd like to ask. Yes, please feel free to unmute yourself.
Thank you, Dr. Gillies. My name is Guanan. I'm a Yale researcher doing clinical trial patient matching. So it's very interesting to hear your perspective. I also noticed that there are so many gaps in the whole process, from designing the trial to patient screening and recruitment and to retention. So in your perspective, like, what do you think is the most critical problem in this whole workflow that we should resolve first? Because I'm working on the more helping using AI tools to identify more patients so we can increase the pool of patients who are potentially eligible for trials. But there are also other problems at the initial design of the trial, or how we can keep the patient retention to the trial. But in your opinion, what is the most important and most, I think, approaching problem that we should resolve first?
Okay, so thank you for your question. I will answer this from a UK perspective, and then I'd be really interested to hear if you guys in the US have a different perspective. In the UK right now, it is incredibly difficult to run clinical trials because our healthcare system is broken. So within the National Health Service, within the UK, clinicians are incredibly strapped for time. And I think trying to ask people to have an additional conversation about a trial is, I think it's just creating another barrier. So right now in the UK, definitely the NHS infrastructure is not able to support, I think, the way we want to run trials. So we have trials being closed down because they're failing to recruit, and it's largely due to an inability from the system to be able to deliver them. One of the other areas I think that we also have to be careful of is there have been lots of efficiencies proposed for trial design. So for example, using health systems data, but there is definitely, and we have a PhD student who's from Liverpool, but with us for a couple of months. And it's been really interesting working with her to understand, these new design concepts also have challenges, right? So actually getting access to health systems data is really difficult. And then having it in a form that you can use and analyze within your trial is also really difficult. But yeah, I think in the UK right now, it's the state of the NHS. I mean, I don't know do you have perspectives on in the US system, what makes it easy or hard? What do you think the biggest thing is?
Yeah, I think like you said, I mean, getting the data access is definitely challenging, but I think in individual institutions like Yale and other, different healthcare centers, we all have the data, but I think how we can efficiently use the data is part of some problem we are dealing with each individually. So we don't have, I think, a systematic way to do the approach. But that way, I think, in my opinion, that by some of my studies, our design tool is definitely increasing the pool of eligible patients for trials, but we still notice there are some gaps between eligible to accrual. And then further, we didn't do anything related to the retention, but I think I can definitely imagine there will be some problem in there as well. So like how the staff approaching the patients, how the physician are talking, mention that trial to the patient will also be something that is not going to be very easily tackled by just some AI tool or others. So I think, yeah, but that is my approach. My approach is that to utilize the existing rich data inside the health systems so we can at least first increasing the pool of eligible patients. And then further, we want to monitor what is the gap further along the process, and in order to develop further some other tools to help them to close the loop. Yeah, it's just my approach.
Very interesting. Thank you.
Yeah, thank you.
So I've had the same observation that you've had about the UK health system. We do international trials and we've had UK centers, and the recruitment there has been disappointing for precisely the reason you quote. They're just overwhelmed with clinical care. And when we've talked to them one-on-one, we get exactly that answer. It's very difficult to recruit. In the United States, it's not quite as bad, but that still is a major factor. Busy clinical practices. You have to figure out ways to optimize the recruitment process so that you're not costing that physician time, which costs him money, because of the way they're compensated is based upon basically you eat what you treat. And that's a problem that we see. Not as big as in the UK, but certainly a problem. I have a comment for you about the pen. Why it increases recruitment. So the answer actually comes from the conflict of interest in studies. It turns out that the giving of any gift, regardless of how small, creates a sense of obligation. And so the person who gets the pen will feel, even if it's modest, an obligation to continue to perform. And that's why many of the conflict of interest rules have no minimum. They say anything, any gift at all is considered a conflict. So, and it has to do with that sense of obligation. And then,
sorry, just to come
ahead.
back on that. So the reason I kind of made the funny comment is because there is also an evaluation of a pen to improve retention delivered at retention, and it doesn't seem to have an effect. So it just seemed, and I don't know enough about the trials where the pen was delivered at recruitment. I'd need to go back and look at it. Could be a temporal issue as well, but yeah.
And then you suggested that unmasked trials. I do eye trials, so we don't talk about blinded. Unmasked trials seem to improve retention. We have seen with unmasked trials, because that's often what we have to do, given the fact that we're doing surgical versus medical interventions and things of that sort, where masking is not practical, is that in a comparative effectiveness trial where one is newer and therefore perceived to be better, even if it's not, there's a differential loss to follow up based upon treatment assignment in an unmasked trial. And that's problematic. Now, we've never had one big enough to be truly problematic, but at least theoretically, it drives us nuts.
So it was open versus masked was for recruitment, not for retention.
Right.
Yeah. So that trial, the trial that the evidence comes from is a drug trial. So it was placebo controlled. So I agree. I think it's definitely trickier. But you do have a differential for when patients know
Right.
potentially of the different intervention allocation.
And I think we have a few questions in the chat. Jade, would you like to pose your question? And then Laura?
Sure. I know that you're in the UK, but I'm just for people on the call that are in the US or anyone that knows, I'm just asking if there's like any central websites or like registries where someone who's interested can go and look at clinical trial opportunities to sign up as a participant, or vice versa, where we could like post a clinical trial to recruit participants.
So I can talk about what happens in the UK. So there isn't a central repository, but often patient advocacy groups or charities will often list trials that are running currently. And sometimes actually hospital trusts will also post the trials that are running currently in their area, so people can try and identify them. I'm fairly sure there isn't, one central repository that people can sign up to. There was, I think years ago, like 20 years ago in the UK, well, in Scotland, actually, just in Scotland, a media campaign called Get Randomized that tried to encourage people to, if they were offered a clinical trial, to consider taking part. And it did have a linked website. I can't remember if it listed clinical trials on there, though.
And I think similarly in the US, a lot of hospitals or academic centers do have repositories for the trials that are ongoing, and those are often used by patients. We have clinicaltrials.gov, which is a registry, but it's billed as also a way for participants just to identify trials and that are ongoing or recruiting. If that's just another way to do so. So, and again, also with advocacy groups in the US. There are trials that are also posted there. So there may be other suggestions or other places that we can highlight for the US.
And I was just asking if the studies, or if you know of studies, have looked at any differences between who is doing the consent process, whether it's a physician spending time with the potential participant, or if it's handed over to a clinical coordinator, and how that is handled.
Yeah, so great question, Laura. So often what happens in many of the trials that we're doing is the initial conversation. So we do a lot of elective surgical trials. So the initial conversation will be with the consultant surgeon, and that's often the piece that we audio record because it's the initial introduction. Then the patient will be handed over to a research nurse, and people are, and you can imagine why, people often don't want to be recorded, and we often fail to record that part of the consultation. So sometimes it can sound in the initial consultation, oh, this patient's definitely going to take part, and then they talk to the research nurse, and all of a sudden they've not consented, and we've lost that bit. So I think there probably are differences. I think potentially patients may feel they can say no easier to the research nurse than they can to the consultant surgeon, for example. I'm hypothesizing. There is a study by Nikki Mills from Bristol. Jenny Donovan is the last author, and they did it from an economic analysis point of view, where they looked at nurses versus consultants for having conversations about the trial with participants, and because they wanted to see who was better and whether there was a cost implication. So there is a study out there on that. It's from a few years back.
Okay, thanks.
We are at 9:31. Thank you so much, Dr. Gillies. If there are any lingering questions, I don't know if Dr. Gillies has a few minutes to stick around just to answer anyone who may have questions. But thank you all for your attention and joining us today. And thank you again, Dr. Gillies, for your excellent presentation.
Thank you.